fetal blood. So about the physiology of fetal blood, the formation of blood cells is called as the hemopoiesis, isn't it? The formation of blood cell is called as hemopoiesis. And these hemopoiesis initially it started, okay, after the 14 day of fertilization. 14 day of fertilization, this formation of blood is started, okay, formation of blood is started, fine. And this is the embryonic phase, okay, this is the embryonic phase, embryonic phase. Now after, you can say, this formation, during the 10th week, the hemopoiesis is formed inside the liver. The cells are, you can say, formed in the liver, and this story is the 10th week of pregnancy. Okay, so what is happening in the 10th week of the pregnancy? The formation of blood cells is, you can say, mediated by the liver, okay, it's formed by the liver, but gradually, slowly, it's shifted to the spleen and bone marrow. But near the term, okay, you can say that near the parturition, near the term, the business of blood cell formation is only limited to the bone marrow. Fine? No problem? Yeah? So the fetal hemopoiesis, the hemodynamics of the fetus is initially started, okay, since the 14th day of fertilization in the yolk sac. In the yolk sac it is started, okay. But in the 10th week of the pregnancy, this hemopoiesis, you can say, function is done by the liver, okay, it is done by the liver. Then slowly or gradually, you can say, it is shifted to the spleen and bone marrow, or near the term, the bone marrow become the major site of red cell production, okay. And you know, the red cell production is termed as the erythropoiesis. Write it down. The red cell formation, that's called the RBC formation, is called as the erythropoiesis. Okay, no problem. Now, the fetal erythropoiesis, okay, it is regulated by the fetal erythropoietin. Erythropoietin is a hormone, okay, which is necessary for formation of RBC. Are you getting the points? Which is necessary for formation of the RBC, called as erythropoietin, secreted by the, erythropoietin is secreted by the kidney. Erythropoietin, because this erythropoietin is only, you can say, secreted by the fetal itself, because the you can say the maternal erythropoietins that are not able to cross, the placenta. So the erythropoietic function is only dependent on the fetal erythropoietin itself. No problem? Yeah. In the early period, the erythropoiesis formation of, you can say, the RBC is megaloblastic. Okay, megaloblastic. In initial time, the RBC's structure is, you can say, the large RBC structure. Fine, but near the term, or you can say near the delivery, you can say the structure of RBC become the normoblast, or we can say the normal in shape. Normoblast. Okay, it is this story is about the near term, means near to the delivery. Okay, so what is happening in the fetal blood, and you should write it down, the concentration and the number of RBCs. The RBCs number present in the fetus is 5 to 6 million per mm of cube. Okay, the RBC number is 5 to 6 million per mmq. Okay, and if we talked about the life cycle of this RBC, the fetal RBC life cycle, it is less than 2/3 of the adult, you can say, life cycle. The adult life cycle is the 120, and if you reduce it to, you can say, 2/3, it's become the 80 days. Okay, so lifespan of the fetal RBC is 80 days. Okay, and you can say the structure is megaloblastic, the large structure, the RBC form in the large structure. And if we talked about the concentration of hemoglobin, it is approx 14 to 16 gram per deciliter. Okay, no problem. And sometimes what happened, there is a, you can say, lysis called as the hemolysis due to the RH incompatibility, by the, you can say, anti-RH antibody. The maternal anti-RH antibody will destroy the fetus RBC, result into the mass destruction of fetal RBC. Okay, and sometimes it causes the death called as the erythroblastosis fetalis. You should write that down, called as erythrocytosis fetalis. Okay, erythroblastosis fetalis. Okay, this is characterized by the RH incompatibility. The first pregnancy is normal if the mother is RH negative and the fetus is RH positive. Okay, then the first pregnancy is normal, but the subsequent successive pregnancy result in the destruction of fetal RBC and result into the erythroblast fetalis. Okay, erythroblast fetalis, no problem. Now the hemoglobin concentration is 14 to 16 gram, and these hemoglobins, you can say, bind more profoundly with the oxygen, because the fetal lungs is, you can say, solid. In the embryonic period is not functional, so hemoglobin will bind more, you can say, the affinity towards the oxygen is tight as compared to the adults. Fine. So it is about the fetal blood or hemopoiesis. What we studied that the hemopoiesis or formation of the blood cell is started since the 14th day after the fertilization in the yolk sac during the embryonic period. But the true hemopoiesis started on the 10th week in the fetus liver, but gradually, or we can say slowly, it shifted to the spleen and bone marrow. But near the term, or you can say near the delivery, it only restricted to the bone marrow. And mainly the RBC cells are formed in the bone marrow, and the formation of RBC cell is we term as the erythropoiesis. And this erythropoiesis is, you can say, this erythropoiesis is not dependent upon the maternal erythropoietin, the hormone which is responsible for the formation of erythropoiesis, because the maternal erythropoietin is not able to cross the placental barrier. Okay, so the erythropoiesis is only truly dependent upon the fetus erythropoietin itself. Okay, no problem. Now let's move ahead and discuss about the fetal defenses. Okay, or you know that the defenses is done by which type of our blood cell? Yeah, it's a WBC, or also called as the leukocyte. So the leukocytes, you can say, start to form, the leukocyte start to form after the 2 months of gestation. Okay, make the heading leukocytes and defenses. So this leukocyte will appear when? After the 2 months of gestation. After the 2 months of the pregnancy, these leukocytes are developed. So then this leukocyte is meant for providing the defense to the fetus. Initially, you know that the fetus is developing in highly sterile environment. Okay, the fetal is initially the fetus is developing in a highly sterile environment. Okay, so this sterile environment don't need the protection from the leukocyte or any defenses, but there is antibodies, okay, which is you can say provided by the mother, okay, which is provided by the mother during the intrauterine life. During the development, the fetus are getting the one antibody called as the IgG. Okay, this antibody is given by the mother side, and this antibody, you can say, going to the fetus in the 12th week. After the 12th week, the antibodies are going to supply to the fetus, and it's surprising that as soon as fetus is developed properly, the concentration of IgG is more than 10% to the, as compared to the, you can say, as compared to the maternal antibody. Means mother is giving 10 times more, you can say, antibody to the fetus, 10 times more as compared to their own antibody. She is giving the 10 times more antibody. So concentration of the IgG is 10% more as compared to the mother IgG, Okay, no problem. Now, so it is about the fetus antibody, and the one thing which you should keep in your mind is that the formation of WBCs, you know that WBCs are different types. So these WBCs start, you can say, formed, and as well as the specialization in the thymus gland and spleen. In the initial period of the life of fetus, these leukocytes and all the, you can say, the types of leukocytes, they are formed in the thymus and spleen. Okay, no problem. Now, there another antibody called as the IgM. Okay, this IgM antibody, it is, you can say, predominantly it's a fetal origin. You know, we have the 5 class of immunoglobulins or 5 class of antibody. The one of the type is the IgG, which is we acquired from our mother, and another one is called as the IgM. Okay, another one is called as the IgM. This IgM antibody, they are, you can say, not come from the mother side. It's predominantly, or you can say it's only fetal origin itself. It's only from the fetal side. So if through the, you can say, if somehow this IgM antibody is, you can say, increased in fetal blood, it shows that fetals have a kind of infection. Fetal have the kind of infection, because initially this IgM antibody is not activated, because the fetus is developing in the sterile environment. It don't need to synthesize their own antibody. But if somehow this IgM antibody concentration is high, it denotes that the fetal is suffering from any kind of infection. And this is you can say, this analysis is find out by one kind of specific test called as the chordocentesis, called as the chordocentesis. In this chordocentesis, you can say a small amount of sample is taken from the umbilical cord, okay, and then it is analyzing, you can say, laboratory, and if there will be elevation in the number of IgM antibody, then it shows that fetus is suffering from any kind of infection. Fetus is suffering from any kind of infection. Now let's move ahead and discuss about another system called as the GIT, or gastrointestinal tract, or also called as the digestive system. You understood this? Yeah, no problem. Now let's make another heading and understand the fetal GIT. The fetus GIT, you know, the digestive system is served for the digestion of the food, okay, and yeah, extract the energy. But you know that in the case of fetus, they don't need to, you can say, channelize their digestive system. They don't need to waste their digestive system in initial period, because there is mother which is providing all the nutrient requirement, okay, providing all the nutrient requirement. So, but you know that the things have to start, you can say, have to stimulate. Most of our body organs need stimulation during the intrauterine life. If it will not stimulate during the intrauterine life, then you can say there will be a problem in the development. There will be a problem in the development. So intrauterine stimulation is needed, okay. So in the case of the GIT, or gastrointestinal tract, initially this gastric tube is formed, okay. You know, we seen that from the which derm? Endoderm. From the endoderm, this GIT is derived. Fine. And there is a formation of gastric tube, which is going to specialize and form the tubular structure called as the GIT, gastrointestinal tract. And one thing we also know, that a baby, you can say, don't need to extract the energy from the food, because already, you can say, pre-prepared, you can say, prepared food is going to supply by the help of placenta, okay, from the mother side. But in the, you can say, developing period, it needs stimulation, okay. You know, if suddenly if it come to the external environment, then it's very hard, no, and fetus, most of the organs are, you can say, if it is not adapted in intrauterine life, then it's very difficult to adapt after the intrauterine life. So inside the mother itself, okay, inside the mother itself, during the 10 to 12 week, during the 10 to 12 week, what is happening? 10 to 12 week, we studied about the amniotic fluid, okay, we studied about the amniotic fluid. So in the 10 to 12 week, some of the amniotic fluid is, you can say, swollen, you can say, swollen by the, yeah, fetus, by the fetus. And how much? It estimated the 500 ml. And how it's confirmed that the baby is, you can say, getting this amniotic fluid inside her GIT? By analyzing his or her meconium. Meconium, as we studied, it is the excretory material of the fetus, okay, it's the excretory material of the fetus. And after analyzing the meconium, it shows that it is composed of the some of the, you can say, bile pigment, bile pigment like biliverdin, bilirubin. Okay, it also carries the lingo, the hairy structure, the lingo. Apart from that, it contains some of the water portion. Okay, so this is a composition of the meconium, which shows that in the 10th or 12th week of fetus start to swell in some of the fluids. Some of the fluid, which fluid? Amniotic fluid. Got the points? No problem. And now let's move ahead and discuss about the fetal urinary system. So fetal urinary system, let's talk about only the kidney. So the initial, you can say, part of the, the structure and the function of the kidney is called as the nephron. Okay, make the heading urinary system. So initially there is no need of the kidney for, you can say, excretion purpose, because there is already presence of placenta which is working, which is providing the excretory function. Okay, the only need of this urinary system is to provide, you can say, and provide mainly the, you can say, the purified mainly the blood. Okay, purified mainly the blood. So on around the 14th week, on around the 14th week, the metanephric neuron, not a neurons, it's a nephron, okay, it will, you can say, change, it will change to the matured nephron. It start to, you can say, specializing. Okay, it start specializing the metanephric nephron, it start specializing. Okay, so at the 14th week the loop of Henle is formed, and by the end of the first trimester the nephron metanephric kidney become active, and it become the mature, and it starts secreting the urine. It start to secreting the urine. Okay, no problem. Now, so this is all about the fetus function and the nervous systems or endocrine systems. Okay, there's no any, you can say, such a significant things to, you can say, discuss in their development time, because if we talked about the nervous system, then the fetus body movement, okay, it is denoted, it start denoting, and the heart rate, it start functioning, and breathing movement, it all are, you can say, present in the fetus. Okay, and after the, you can say, 20th week or 14th week, the baby movement is denoted by the reactive, no reactive. Okay, the most 75% of the you can say spin of the baby in the uterus is you can say active state, or you can say the reactive state, and 25% of the state is a non-reactive phase. Okay, in the non-reactive phase. And if we talked about the respiratory system, then lungs is not mature and breathing is irregular till the 20th week. Till the 20th week the breathing pattern is irregular. Okay, and if we talked about the fetal endocrinology, then there is, you've seen, because we've seen in the development of the fetus or growth of the fetus, there is a need for the growth hormones, and these all growth hormones need to synthesized by the fetus endocrine system. So there is a secretion of growth hormone, prolactin, ACTH. Okay, ACTH, and also it's seen that the female fetus will not secrete the hormones for development of their reproductive organs, but the male fetus starts secreting the TSH, the, you can say, the testicular stimulating hormones in the intrauterine life itself, Okay, so let's conclude today's class. What we studied? We studied first about the germ layers, okay, the germs layer, all the three germs layer and their derivatives. Then we moved ahead and we discussed about the fetal physiology, and we seen the circulation, okay, the how the, you can say, the fetal hemopoiesis is different from the adult hemopoiesis. We seen the development of GIT, we seen the development of the urinary system. We also discussed about the development of nervous system and endocrine system as well as the respiratory systems. So by this we are finished with the reproductive system lectures. We will meet with the new lecture series. Thank you with having me. Bye. Have a nice day.